Hello, I'm Dr. John Leonard, and on behalf of CME Outfitters, I'd like to welcome you to today's educational activity entitled Determining a Patient's Risk, Identifying Rapid Progression of Follicular Lymphoma. Today's program is supported by an educational grant from Genentech Incorporated. This activity is brought to you by CME Outfitters, an award-winning, jointly accredited provider of continuing education for clinicians worldwide. Again, I'm Dr. John Leonard. I'm at Weill Cornell Medicine and New York Presbyterian Hospital in New York. Joining me today is Dr. Carla Casulo, an associate professor at the James P. Wilmot Cancer Institute at the University of Rochester. Welcome, Carla.
Thank you for having me today.
The learning objective for today's activity is to implement risk stratification techniques to identify patients with follicular lymphoma who are likely to experience progression of disease within 24 months. So Dr. Casulo, why don't we start with just kind of an overview of follicular lymphoma and really setting the stage for this POD24 question or issue that you've really been a world leader in identifying and addressing.
Sure. So I think it'll be good to start with an overview of follicular lymphoma. It's the most common indolent lymphoma diagnosed in the United States and Europe, representing about 20% of all non-Hodgkin lymphoma. And the patients affected are usually older adults with an average age in their 60s. Most patients are advanced stage at the time of their presentation, and often they have asymptomatic lymphadenopathy, but despite that, they end up having high tumor burden disease based on Guelph criteria. Not very many patients have B symptoms. And despite all of that, the overall prognosis of follicular lymphoma is actually quite favorable, where overall survival at 10 years is about 80%. But there is significant heterogeneity to the disease, and a number of subsets have emerged, among which are the early progressor group. And these patients have a higher risk of death, as well as death secondary to transformation. What we know about follicular lymphoma is there are many well-defined biologic characteristics. Primarily, the cells are what I envision as the evil twin of a normal centrocyte. They're derived from the germinal center of the lymph node. They express CD10, CD20, and most patients have a 14-18 translocation, which results in constitutive overexpression of BCL2. And as you can see on this slide, follicular lymphoma has this nodular pattern, and it's characterized also on a molecular level by loss of function mutations that are involved in these genes involved in epigenetics, and that leads to suppressed gene transcription. But in addition to that, there's a very robust microenvironment that is very conducive to supporting the follicular lymphoma tumor itself. In terms of prognosis, as I mentioned earlier, the overall survival is really incredible for a cancer. If you think about it, 80% of patients will remain alive at 10 years. And this has been well established in a number of different data sets. The one that we're looking at right now is coming from Sarkozy and colleagues, where they looked at a pooled cohort of patients from the United States and Europe, demonstrating that overall survival is really quite good. And when patients do die from follicular lymphoma, the vast majority of the time, then it is a lymphoma-related death. It affects about 10% of patients. And other causes of death include treatment-related deaths or deaths from histologic transformation. But overall, most patients do quite well. And that's where the field is actively seeking to define subsets of patients that might not do as well so that we can tailor treatment a little bit better.
So Carla, you see a lot of follicular lymphoma patients, and I wonder, when you see a patient in your practice, how you kind of address this issue with the patient. It really, I find that the prognosis is something when people hear they have an incurable lymphoma, it's really difficult psychologically to deal with. Then again, the survival, as you just noted, is quite good. So how do you kind of think of this with a newly diagnosed patient? How do you typically present it to the patient? And how do you deal with the issue of cure? I find that very hard when people ask, well, are you going to ever cure this, or how are you going to cure this, or will it ever be cured? How do you think about those issues in your patients?
Right. I think that's a good question that we all deal with on a daily basis. And sometimes I think that we're being a little bit over fatalistic and thinking that there's no cure, because if someone really is able to live 25 or 30 years with a disease, for all intents and purposes, it's equivalent to cure. So I think that I'm becoming a little bit more thoughtful about that, saying, we define it so strictly, something that will never ever come back. And I think that it's a hard line, I think, at times. But with regards to how we approach patients, what I try to say is that this is something that you'll likely have for the rest of your life. You may not die from it. There are a multitude of really excellent therapies out there if and when treatment is needed. And there are some ways that we can help to refine what your risk of progression is and what the risk of dying from lymphoma is at the time of diagnosis, based on certain risk models like FLIPI or FLIPI-2, some of which are used more in the United States, some of which are used more in Europe. But that's a basis upon which we can address the risk of prognosis.
It seemed like, in looking at this Sarkozy paper that you referenced, really the chance of dying of other malignancies or a treatment-related death is pretty low for these patients. And I wonder how much of this has changed over time as treatments have changed and we're getting away from chemotherapy. But either way, it seems like most of these patients are going to do well for a long period of time. We'll get to transformation and concerns about that as well in a little bit. But any thoughts about how that's evolved kind of over the years?
I suspect that is getting continuously better. Back in the early 2000s, the vast majority of patients were treated with R-CHOP that has an anthracycline, and it has more toxicity. There is a small risk of death from second cancers, as was noted in the previous slide. But I think that because more and more therapies are evolving that have a different risk profile, that can be sequenced in different ways, I suspect that risk will continue to diminish over time. And we're getting so many new drugs approved in this space too, that I feel that is going to be a game changer in the next couple of years as well.
So I think the other thing that it highlights, and we'll move on to risk in a second, is the need for good survivorship care and making sure our patients, looking at this kind of greenish other malignancy cause, that patients get their mammograms and
Right.
colonoscopies and other things. I'm sure you, like I, have had patients with other malignancies
Right.
as well that we need to keep in mind. And it's almost embarrassing that they see us, but yet might in some cases not be as up to date for whatever reason on their screening. So we really need to keep that on our radar screen to make sure.
Absolutely. Absolutely. Quality of life too is a really critical thing, given that, as you said, there's a psychological impact of having a lymphoma that putatively it would be something for a very, very long time. It's really scary, especially for younger patients, where about 10% of patients or so are under the age of 40, which is sort of scary to think of being 60 and still having a risk of having this for a really, really long time. So I think that the quality of life aspect and the patient reported quality of life outcomes are incredibly important too.
So now let's move to risk in our polling question. There have been a number of different prognostic scores that have been developed for different types of lymphoma. Our polling question asks, which of the following is a factor that's used to define high-risk follicular lymphoma using the FLIPI-2 model? Elevated LDH, the 14/18 translocation, cytokine release syndrome with therapy, beta-2 microglobulin, or I'm not sure.
So this is a good question, and we can walk through each individual answer. So elevated lactate dehydrogenase is a little bit of a red herring, because that is in the original IPI. If you remember the acronym APPLES with 1P, LDH is a risk factor in that, but not in the FLIPI-2. So that one's not correct. The presence of the 14/18 translocation, as we said earlier, is sort of the biologic characteristic of follicular lymphoma that doesn't have prognostic impact or is used to define high risk in this model. The occurrence of cytokine release syndrome with therapy as well is not what I would choose, because this was not built around treatment, and the occurrence of this is really observed with therapies like anti-CD19 CAR T cell therapy or with bispecific antibody therapy, and it's not really relevant in this particular situation. So the answer is elevated beta 2 microglobulin. Of course, I'm not sure is the right answer if you're not sure, and sometimes we're not. So we'll learn in a few minutes that some of these things are relevant in some models, and then when they get validated in other data sets, sometimes they don't end up being relevant anymore.
Okay, so we're now going to move to defining high-risk follicular lymphoma. And we highlighted that the majority of patients do quite well with FL, but there are subsets of patients that do poorly. And I think the kind of the holy grail is to figure out who those people are, to figure out how we should approach them differently to hopefully overcome their risk features. So Carla, why don't you take us through some of the tools that are out there and the attempts that have been out there to try to identify a high-risk group of patients?
Right. So the way that I think about that is, patients that don't do as well as the average, that's the way I think about a high-risk group. So you'll have your super responders that'll do really fantastically well and never have disease recurrence. But the vast majority of patients with chemotherapy will have they'll have response that will last for many years. And as I mentioned, about 10-year survival of 80% or so. So who deviates from that average? That's the group that we've tended to focus on. And my view would be to characterize that group of less favorable patients as those that have early disease progression. That means patients that have had disease recurrence within 2 years of their diagnosis, patients that have multiply relapsed or refractory disease are another group that tends to have less favorable outcomes. And then those that have transformation to a more aggressive lymphoma are also a group that's being heavily studied. And particularly those that have transformation early in their course, those patients also I view as having high risk of poor outcomes. And I've sort of loosely categorized them as having a high risk phenotype. There are a couple of examples noted on the next slide here to exemplify a little bit more who these groups of patients are. So the first group here noted in panel A are patients that have decreased survival after subsequent lines of therapy. This was a paper published by Connie Bat-Levy at Sloan Kettering. It was a single institution study looking at their patients with follicular lymphoma and how they did after they received different lines of treatment. And you can see by the bars that after each and every treatment a patient receives, unfortunately, their response rates are lower and their progression-free survival is shorter. So that interval in between each treatment gets progressively shorter and shorter. So that suggests that patients that need multiple therapies over the course of their lifetime, that tends to affect their overall survival. The other group that we've categorized many years ago now was a group of patients that had that early disease recurrence. That sort of aspect of follicular lymphoma biology is being explored as to what it is about patients that causes them to relapse early. There's lots of things that are being proposed as to why that is, but very, very consistently, studies have shown, and our validation in this panel in the middle from a big group of 5,000 patients treated on multiple studies showed that if a patient has early disease recurrence, they won't do as well as if they have disease recurrence after that period of time. And again, the reasons that the reasons behind that are currently being explored. And then lastly, as I mentioned, that time to transformation and overall survival based on transformation. This was a big paper looking at outcomes of patients in an Italian study where those that had recurrent disease with follicular lymphoma did much better than patients in whose disease recurrence was based on transformation. And I would say that these are not exclusive categories, but these are the categories that I view as the patients that are most vulnerable.
So I think this is a key bit of information, the idea that we have these different parameters that we can look at diagnosis, and then the parameters that we can look at the time of relapse. How do you use that in guiding therapy? And I know, if you've seen one follicular lymphoma patient, you've seen one follicular lymphoma patient. It's kind of, it
Right.
doesn't always fit a pattern, but in general, in your practice, I mean, to me, it seems like if you get a short remission, you do something different. If you get a long remission, you can stick with the same sort of thing, as a very kind of 50,000 foot view of that. But how do you
Exactly.
generally think of these and use them?
So as we said earlier, the prognostic marker field is exploding right now. There's so many ways for us to say this patient will do not well, this patient will do very, very well, this patient will do moderately well. But ultimately, what's the actionable information with that? So what this slide shows us is just to really illustrate that we can define prognosis as a wave over a patient's lifetime. We can define it at the time of diagnosis using some of these clinical models. We can define prognosis based on some of this tumor-specific biologic information, the genes, what's in the environment. And then we can look at the end of therapy prognostically, what impacts that? Is it a PET scan that is informative? And then again, at the time of their recurrence, progression. So I think out of all of these, the one that's probably most actionable is the event at the time of their recurrence. So that sort of time to their disease coming back, if it was within the 12 to 24 months, we know that those patients don't do as well. So that's an opportunity to explore newer therapies perhaps, or put them on a clinical trial. Unfortunately, though, the rest of the prognostic markers are really more to define and have a discussion about what's likely or not as likely, like from the 30,000 foot view, like you said. But unfortunately, we're not at the point where we can use that to change our treatment, at least not in 2022 as part of standard of care.
One of the things you alluded to is transformation, and I want to ask you a little bit more about that. But we have a polling question that really gets into that issue, and I think is going to be part of this discussion, although there are other factors here. So our polling question asks about the relationship between maximum standardized uptake value, or SUV max, and the risk of transformation. Is it directly related? Is there no relationship? Is it inversely related, or only at high levels, or the old I'm not sure?
This is a really good question. And if you answered, I'm not sure, that's probably really smart, because this is fraught with controversy. So when we order a PET scan, which is considered to be a really important standard to kind of refine our decision making, and absolutely, I would recommend it at the end of treatment, because having your response by PET is very important, and more so important than the response by CT at the end of treatment. Sometimes if you have a response by CT after someone's been treated, it can underestimate a patient's response, and it may not capture other sites of disease. So I'd absolutely recommend PET scan at the end of treatment to assess response. But the question of the baseline SUV max is something that we've been thinking about for some time. So when you order a PET scan at the time of their diagnosis, and you'll see that some of the lesions have an SUV of 11, and some may have an SUV of 16, and some might have an SUV of 3. There's some small studies that have suggested it's completely related to the risk of transformation. But when we looked at some of the big studies, it actually turned out that there was really no difference between the baseline SUV max and the risk of transformation. So it continues to be something that we're exploring on a research side.
So what is your typical clinical practice? I mean, we tend to still, and I acknowledge the controversies you mentioned, but in practice, certainly at the extremes, we're either concerned or relaxed about the risk of transformation, but there are a lot of patients that are in the middle. Do you routinely biopsy patients? Do you, again, it's hard to generalize, but it seems to me like if somebody's got a high SUV, you really should at least there try to biopsy and see. It may turn out to be still follicular lymphoma, but it seems to me like that's a scenario where you're at least inclined to look a little harder.
Right. Well, this study from Dr. Trotman and colleagues, and this was a pooled study of several different other studies in Europe, and then the gallium study also showed that the baseline SUV, it actually didn't predict for poor outcome, and it actually was not associated with transformation, at least in their hands. Now, I think it's hard when someone has every single other lesion in their body on PET has an SUV that's in the same range, like, single digits or up to 10. And then there's one isolated area with a drastically increased SUV. I would agree it raises concern that there might be an outlier, particularly if it's an extranodal site, like a lesion in the bone that's very hypermetabolic. That would absolutely be concerning for focal transformation, which can happen. But at least the data is not consistent on that. And I think that that's where practice and the data sort of sometimes are discordant, because you never want to miss it. And sometimes a biopsy will put everyone's mind at ease.
Yeah, I've had more and more patients as time goes by where they've had high SUVs. I was convinced they transformed. We get the biopsy and it's follicular still. And I never know what to do. I think more often than not, it's other factors that decide, do we treat them more or less aggressively? If it's an older patient versus a younger patient, or, your general suspicion, what they've had before, et cetera. But it's part of the art of follicular lymphoma.
Yes.
We love PET scans. They answer all these questions for us, but they often don't. So.
Right, exactly.
So let's get into some of the newer ideas or the newer concepts of looking at risk and those prognostic scores that have started to take molecular features into account, and how are they leading us even further down the road, or are they at this point?
So I think that it's still a research question, and I view the addition of this molecular information as sort of setting the table. So we start with like your tablecloth and then your plate, and then if you want to get really fancy, you'll add your salad fork and all this other extra stuff. But it's really sort of what can we build on from the most basic information to keep it accessible to the everyday physician. So what this group, there was a group out of Germany that looked at a concept of taking the Flippy score and then mixing it together with mutations of genes to see, does that make our ability to prognosticate better or not? So that's known as the M7 Flippy. And basically they looked at several different genes. They wanted to see which ones were most relevant in follicular lymphoma. And they put it together with Flippy and performance status. And what they found is that if you take your standard Flippy score and then you compare it against this more refined M7 Flippy, the M7 Flippy was better at refining prognosis, to the point where patients who were initially called high-risk Flippy moved into the low-risk M7 Flippy category. And so at the end of the day, the group concluded that it was a more refined way of identifying risk. The problem is that when we looked at it in a different clinical trial and a different group of patients treated with different chemotherapies, it actually did not end up, being able to get reproduced. And that was unfortunate, but sometimes that happens. That's why we have to test these models in different categories. And it also wasn't prognostic in patients that received rituximab in the Nordic study. So I think the message here is that a prognostic tool needs, if it's a good prognostic tool and it's going to be informative, it needs to be agnostic of treatment, meaning it needs to be able to be preserved over time, no matter what a patient gets. And that's something that we're not 100% there yet, unfortunately.
So there was an interesting analysis that's been presented from the gallium study, one of the large clinical trials with, I guess, in some ways more modern therapy, that suggested, or at least gave a hint that certain genetic features could ultimately be influential in choosing which chemotherapy, which we really haven't had a good tool for that in follicular lymphoma. Do you want to mention that for us?
Yes, so that is, I think you're referring to the gene expression profiling. So there was a big study looking at gene expression in patients with follicular lymphoma, and that's a little bit different from mutations. That's just looking at which of the genes are turned on or off. And what they found was that patients with a specific gene profile, they were able to be grouped into either a good risk category or a poor risk category. However, when they looked at patients treated in the gallium study, that gene signature was not prognostic. And it actually mattered what the patients got. So patients who had a low risk gene signature, it didn't matter if they got CHOP, it didn't matter if they got bendamustine, they did just as well. The gene signature score actually wasn't able to differentiate these patients. But if they had a high risk gene signature score, then they ended up having a better prognosis if they were treated with bendamustine. So again, that's really on the research spectrum, but what it suggests is that maybe some of the genes that are turned on or off in these gene signature profiles, they may have a specific impact on how the chemotherapy works and whether the chemotherapy is able to sort of minimize that risk or in some way wipe away that risk. So no matter what the gene profile says, if you get one therapy, it kind of wipes out its importance. So that's the way I think about that particular study and how I apply it in real time.
So Carla, we've covered a lot of ground. Maybe you could just take a minute to summarize some of this important topic for our audience.
Sure. So I think that, as we talked about, there's lots of different ways to predict risk. That doesn't necessarily mean that we can do something about it. And that's sort of the frustrating part. So at the time of diagnosis, we have all these different risk models. At the end of treatment, as I mentioned earlier, the PET scan is really important to define prognosis. And at the time of disease recurrence, understanding the time to recurrence is very important. However, as I said, in 2022, no specific one of these risk models has been able to help us select a treatment. There's one study that was recently published in the JCO and presented at ASH, it was an Italian study looking to see if we could use PET scan at the end of treatment and a research tool called minimal residual disease, looking at circulating tumor cells in the blood, and to see whether that approach could help to define who would be appropriate for maintenance, who would be appropriate for escalation of therapy. So that's what we would call risk adaptation or treatment adjustment based on risk. And that's still an ongoing tool because that study was a negative study. So the authors concluded that we will, at least with this approach, adapting therapy based on risk is not ready for prime time. So we still need to define markers, as I said, that don't have anything to do with treatment, that can be independent of treatment. But I think, as I said, what's probably actionable is trying to affect what a patient is treated with at the time of early recurrence or early transformation, because that's the group that actually we know doesn't do as well. And it's an area also of ongoing research. So if you have the opportunity to refer those patients, or if there's a clinical trial, that would be the approach that I would take. And that's what we currently do in our center.
Well, thanks for a great summary. I want to wrap up with some SMART goals that are specific, measurable, attainable, relevant, and timely. And I think the key points include that risk stratification can be used to predict disease recurrence, but it shouldn't be used generally to select therapy based on what we know today. I want to encourage everyone to watch the companion activities where I'm joined by another outstanding faculty member. The first is evaluating the options, assessing emerging bispecific antibody treatments for follicular lymphoma with Dr. Elizabeth Budde. And the second is entitled Targeting Treatment, Selecting Optimal Therapy for Vulnerable Patients with Dr. Cami Maddox. I want to invite you to visit the CME Outfitters Oncology Hub, where you can access additional activities on relevant oncology topics, as well as resources and patient education materials. Lastly, to receive CME or CE credit for today's program, please complete the post-test and evaluation. Then you'll be able to download and print your certificate immediately upon completion. Thanks again, Dr. Carla Cazzulo, for a great discussion, and thank you to our audience for joining us today.
Thank you for having me.